we'll start this topic, and this topic is very much essential and very much important for the student examination, like while you are doing the any studies in pediatrics, or on for the competition based also. So many questions are asked for the low birth weight babies. So one by one, all the things we will discuss, how to take care of low birth weight babies. Hope you like my video. If you like my video, please do like, and if you dislike my video, please press dislike and give your valuable suggestions so I can make the improvement in further videos. So now we will start the topic. So what is low birth weight babies? So low birth weight babies is depends upon the scenario, like those who are babies in Indian culture, or those who are born in India, in Indian region. The birth weight is 2.5 to 3.5 is we will considering it normal, and in other countries, like it depends on the normal ratio, depends on that they will ask, they will consider the normal values. Then introduction of low birth weight babies. So in detail now we will discuss. Low birth weight babies is less than 2.5 kg or 2,500 grams. Babies have higher morbidity and mortality rate because the chances of complications is very much, and they are more prone to have the diseases, infections, because their immunity is also compromised. Low birth weight baby result from either preterm birth. So what is preterm birth? The babies who delivered before 37 complete weeks of gestation, or due to intrauterine growth retardation, the mother or baby is having any of the condition that can lead to IUGR or both. IUGR is similar to malnutrition and may be present in both term and preterm infants. Neonates affected by IUGR are usually malnourished and have loose skin folds or face and gluteal region. Although the problems of preterm babies and IUGR babies are completely different. So this is the introduction of this preterm newborns. Then next is the normal birth weight is 2.5 to 3 kg. So this is in Indian scenario, or other parameters are also there in other countries, America, UK, US. They were considering till 4.5 as a normal baby. The low birth weight or low birth weight LBW babies, birth weight of less than 2.5 gram regardless of gestational age. Next is incidence. The incidence rate of low birth weight babies is 15 to 30%. The next is neonatal deaths is 75% due to the low birth weight babies. Then next is the infant deaths, 50% caused by the low birth weight babies. And what are the complications of this low birth weight babies? Is prone to have malnutrition, then recurrent infections, and they have a very slow or neurological developmental or handicaps are the most more prone, these are the common complications. Then definition of low birth weight baby. Low birth weight baby is defined as a birth weight of a live born infant of less than 2.5 gram, 5 pounds, 8 ounce, regardless of gestational age. These are the categories of low birth weight babies. First is very low birth weight babies, which is less than 1.5 gram, 3 pounds, 5 ounce, and other categories extremely low birth weight babies, which is less than 1000 or 1 kg. Normal weight at term delivery is 2.5 to 4.2 gram. Then next is, these are the two types of low birth weight babies. First one is the preterm, and other one is the small for date intrauterine or IUGR babies. Intrauterine growth retardation. So what are the preterm babies? Preterm babies are those who having the gestational age less than 37 weeks of gestation. accounts for 1/3 of the LBW. So what is LBW? Is low birth weight. So then next is, so account of 1/3 of LBW. So we are measuring, and if for their gestation age, if there is a 1/3 of decrease in the weight, in that as expected we are considering as LBW. And what is IUGR babies or small for date babies? 10th centile for gestational age and account for 2/3 of low birth weight neonates. So out of out of total babies, low birth weight babies, so the incidence rate of preterm is 1/3 and the IUGR baby is 2/3. Then next is preterm birth. So 4 different pathways has been identified that can result in preterm birth and have considerably evidenced. So precautious fetal endocrine activation, uterine overdistension, residual bleeding and intrauterine inflammation, infection from a practical point, a number of factors have been identified that is associated with preterm birth. However, as an association does not establish casualties. So all these are the causes of preterm. Then next is small for gestational age. So small for gestational age is, being a small for gestation age can be constitutional, that is without an underlying pathological cause, or it can be secondary to intrauterine growth retardation, which is in turn can be secondary to many possible factors. So see the graph. The lower part of the graph is gestational age, and on the longitudinal is birth weight. So those who are more than 19th percentile we will considering as a large for rate, and those who come between 90 to 10 percentile of birth weight, which is as you can see 2.5 to 3.5 is appropriate for the age, and those who are less than 10th percentile of the baby, we have named it small for date. So then other division is, those who are born before 37 weeks we will call it as a preterm, and those who born between 37 to 42 weeks we will give the name term, and other one is the postterm. Like those who born after 42 weeks we will name as a postterm babies. Then what causes infant low birth weight? So one by one we will discuss all the causes. Problems with the placenta, intrauterine growth retardation. So if the mother is having any placental abnormalities, placenta bleeding, or any of the placental abnormality, that can cause IUGR. The complications with the pregnancy, if the mother is having any complications like hypertension, gestational diabetes, there are so many complications which can lead to the IUGR. The next is not enough weight gain by the mother. If the mother is not taking appropriate nutrition, or mother is not gaining appropriate weight, then it will hamper the health of the baby. The next is birth defects. So if the baby is having any birth defects, so the birth defects itself is a huge topic to discuss. So if the baby is having any birth defect related to any system, which can lead to the IUGR. Then poor maternal nutrition, incomplete prenatal care, or drug or alcohol abuse by the mother can also cause low birth weight. So these are the most common factors in our scenario or in our area which can lead to the low birth weight babies. Then next is, what are the physical features of low birth weight babies? So one by one we will discuss all. First is, we will see the face and head of the baby. So face appears small for the disproportionate larger head, sutured and widely separated, and fountains are large. So while we are doing the head and face assessment of the babies, in that you will see the large the head is large as appropriate to the body size, and the sutures between the bones that make the joints coronal, frontal, lambdoidal, these are the sutures, their gap is large. Then next is small chin, protruding eyes due to shallow orbits and absent buccal pad of fat. So that you can see in the baby, those who are having low birth weight babies. Optic nerve is often unmyelinated, but presence of pupillary membrane makes it visualization difficult. The next is ear cartilage is deficient or absent with poor recoil, so that we can see in ear. The next is hair appears woolly and fuzzy, and individual hair fiber can be seen separately. The next is skin and subcutaneous tissue. Skin is thin, gelatinous, shiny and excessively pink with abundant lanugo and very little vernix caseosa. The next is edema may be present in the baby. Subcutaneous fat is deficient and breast nodules is smaller or absent. Deep sole creases are often not present. The next is genitalia. In males, testes are undescended and scrotum is poorly developed. In females, labia majora are widely separated, exposing labia minor and hypertrophied clitoris. The low birth weight baby preterm, what are the problems with these babies? So birth asphyxia, the chances of birth asphyxia is very much common. The hypothermia, because their temperature controlling system, center, body fat and so many contributing factors are not well developed, so the chances of hypothermia is too much in these low birth weight babies or preterm babies. Hyperbilirubinemia, the chances of jaundice is very much common in very much common in the low birth weight babies. Then respiratory distress, because those who have born preterm or before 37 or 36 weeks, their lungs are not well matured or well developed, that is also, and their neurological factor is also contributing to this respiratory distress. The next is retinopathy of the prematurity, the that is also very much common. Then appendix spells, so the baby is having if the baby is having this comorbid factors like any heart disease or the lungs are not mature, that can also lead to the appendix spells. Intraventricular hemorrhage, the bleeding system is also coagulation system is not also well working in the low birth weight babies, that can also lead to the intraventricular hemorrhages. Hypoglycemia and metabolic acidosis is very much common problems with these low birth weight babies. The next is issues in the low birth weight babies care. So as a healthcare professional or as a family members, what others are feeling like problems while taking care of the baby. Central nervous system, the immature of the nervous system is seen by the lethargy and inactive. The baby is not active as the normal. If you compare the babies of the low birth weight babies and the same age group of the normal babies, those who are having the low normal weight, so if you are comparing, you will see that low birth weight babies having the some lacking in the nervous system developments, like baby is not that much actively responding, the milestones are type maybe a little bit delayed. Poor cuff reflex in coordinating sucking and swallowing in babies weighing less than 1.8 gram or born before 35 weeks of gestation. Resuscitation difficulties at birth and recurrent apneic attacks are common. Yes, these are the common, because the respiratory control system is not well developed, their lungs are not well developed, these can lead to all these problems. Then retrolental fibroplasia due to oxygen toxicity is limited to the babies with a gestation of less than 35 weeks. So if you are giving the oxygen or prolonged oxygen therapy to the babies, that can lead to the these problems. Then next is these are more resistant to toxic effects of hypoxia and compared to the term baby. So if you are giving the too much oxygen, that will hamper the oxygen receptors, so that will also lead to the condition of hypoxemia. The blood brain barrier, which is possibly a function of available serum proteins inefficient in preterm babies, thus brain damage may occur at lower serum bilirubin level. So permeability and integrity of the blood brain barrier, so these babies having the lower serum protein level, so that will hamper the condition of the baby. The next is respiratory system. The cuboidal alveolar lining of a babies with gestational age of less than 26 weeks result in poor alveolar diffusion of gases, and therefore the infant may not be viable. Then they pose resuscitation difficulty at birth, often followed by hyaline membrane disease if associated with deficiency of pulmonary surfactant. So in that case we are giving the pulmonary surfactant to the baby, or like if we already aware of the mother's condition, so in that case if the baby is delivering before 36 weeks of delivery, we are giving the dexamethasone to the mother. So the premature babies, we can assure the lung developments in the baby. Then the breathing is mostly diaphragmatic, periodic, and associated with intercostal recession due to soft ribs. Then next is pulmonary aspiration and atelectasis are common. The next is resuscitation problems. So these are the resuscitation problems with the low birth weight babies or preterm babies. Compromised intrauterine environment with higher chances of perinatal asphyxia. So most of the babies are we need to give the resuscitation, or immediately changing of the intrauterine environment to the leads to the perinatal asphyxia. The next is immature lungs that may be more difficult to ventilate and are also more vulnerable to lung injury by the positive pressure ventilation. So the stretchability of the lungs is not that much, the lung surfactant is not that much, the lungs are very fragile. So in that case, if we are giving too much pressure, or we can giving just quite higher pressure in compared to the same age group, same weight babies, that can also lead to the lung injuries. If we are giving CPR, in that case also the chances of injuries to the babies is more. The next is immature blood vessel in brain are prone to have hemorrhage. So that is also one of the complication while resuscitation problems. Thin skin and large surface area which contribute to the rapid heat loss. Yes, that is very much that's why it's very much difficult to maintain the temperature of the baby. Then increased risk of hypovolemic shock caused by the small blood volume. So if we are in these babies, if we are giving the small amount of any IV fluid or anything which can lead to the hypovolemia, and small amount of loss also leads to the hypovolemia, and if we giving the volume, that will also increases the that will also cause hypervolemia. So maintaining the equilibrium between hyper is very much difficult in these babies. So next is cardiovascular system. The closure of ductus arteriosus is delayed among preterm infants. About 1/3 infants with gestational age of 32 weeks or less manifest clinical evidence of patent ductus arteriosus with or without congenital heart disease. So the chances of congenital heart disease is very much common, those who born before 34 weeks of gestation. In grossly immature infant less than 32 weeks shows left ventricular preponderance. The next is gestational system. So these are the things which happen in the gestational system. Due to poor or incoordinate sucking, there are difficulty in self-feeding, although their digestion ability is generally good. The next is regurgitation and aspiration is common because of incoordinated sucking. The next is small capacity of stomach, incompetence of cardioesophageal junction, and poor cough reflex. Then abdominal distension and intestinal obstruction are due to hypotonia. The next is immature of glucotransference system in the liver leads to the hyperbilirubinemia, which may aggravate by the dehydration. Delayed feeding and hypoglycemia, relatively low serum albumin acidosis, and hypoxia in these babies predisposed to the development of keratoconus at lower serum bilirubin level. The relative deficiency of vitamin K dependent coagulation factor are increased capillary fragility, especially following hypoxia, resulting in intraventricular or intracellular hemorrhage. The poor hepatic glycogen stores, delayed feeding, birth asphyxia, and respiratory distress syndrome contribute to the development of hypoglycemia. The next is thermoregulation. So hypothermia is invariable and life-threatening unless environmental temperature is monitored. Excessive heat loss is due to relative large surface area, and poor generation of heat due to the purity of brown fat in the baby who equipped with insufficient thermostat, a high surface area to body weight. The next is infection. The low level of IgG antibodies and ineffective cellular immunity predispose them to infection. The next is excessive handling humid and warm atmosphere. Contaminated incubators and resuscitators expose them to infecting organism, thus contribute to high risk of infection. The maximum tubular dilation ability in the newborn is satisfactory, but ability to concentrate urine is very poor. These are due to the renal immaturity. The blood urea nitrogen is higher due to lower glomerular filtration rate. The renal tubular ammonia mechanism is poorly developed. Thus, acidosis occur earlier. They are vulnerable to develop late metabolic acidosis, especially when fed with a high protein milk formula. Preterm baby have passed 4 to 5 ml of urine to excrete 1 millismol of solute as compared to 0.7 ml of an adult for the same purpose. Therefore, the baby cannot conserve water and gets dehydrated readily. The solute retention and low serum protein explain occurrence of edema in some preterm infants. Then next is toxicity of the drugs. So poor hepatic detoxification and reduced renal clearance make a preterm baby vulnerable to toxic effects of drugs unless caution is exercised during their administration. Nutritional handicaps. Low birth weight babies are prone to develop anemia around 6 to 8 weeks of age. This is due to diminished total score of iron due to short gestation. They may also manifest deficiency of folic acid and vitamin E. Vitamin E deficiency occur among infants weighing less than 1.5 kg, particularly those fed on iron fortification milk formula. These infants are prone to develop hemolytic anemia, thrombocytopenia, and edema at 6 to 8 weeks of age. Vitamin E is an antioxidant, and its deficiency may be associated with oxygen toxicity to vulnerable tissue in the form of retrolental fibroplasia and bronchopulmonary dysplasia. Rapid growth following adequate feeding may cause osteopenia and rickettsia unless calcium, phosphorus, and vitamin D are administered. Then biochemical disturbances with the low birth weight babies. These babies are prone to have hypoglycemia, hypocalcemia, acidosis, and hypoxia. Low hepatic glycogen stores with rapid depletion in stress place these infants at increased risk of hypoglycemia. Immature glucose hemostatic mechanism in premature babies can also lead to decreased inability to utilize glucose and resultant hyperglycemia, especially during stressful period like infection. Early onset of hypocalcemia presenting within 3 days to life and usually asymptomatic, detected on investigation. It is especially seen in premature babies, infant of diabetic mothers, and those with birth asphyxia. Feed with higher phosphate load such as cow milk and some formula result in hypophosphatemia with subsequent hypocalcemia. Then next is hematological abnormalities with these babies. Anemia. So already we have discussed accelerated destruction of fetal RBCs, low reticulocyte counts, and inadequate response to the bone marrow to erythropoietin cause anemia to the prematurity. Low iron store, higher incidence of sepsis, and frequent blood sampling in low birth weight babies may lead to severe anemia. Then polycythemia, placental insufficiency with intrauterine hypoxia leading to stimulation of erythropoiesis and result in polycythemia, especially seen in IUGR babies. Polycythemia produces hypervaricosities with decreased organ perfusion. Manifestation including jitteriness, respiratory distress, cardiac failure, feeding intolerance, and hypocalcemia. Then indications for hospitalization of these babies. So if the birth weight is less than 1.8 kg, in that case we have to bring the baby to the hospital. The next is if the gestation age is 34 weeks, so in that case also we need to hospitalize the baby. Unable to feed, if the baby is not able to feed. The next is sick neonate, irrespective of birth weight and gestation. So it doesn't matter whether the baby is weight, age. If the baby is sick, we need to hospitalize the baby. Then danger signals, early detection and referral. Lethargy, refuse to feed. If the baby is lethargy and refusing to feed, in that case also this we will take as a danger sign, and we immediately need to give the attention to the baby. Then hypothermia, if the temperature is low in the baby, in that case also we need to early identify and resolve the condition. Tachypnea, grunt and grasping apnea, so it will lead to the baby is having any respiratory thing, or a pre-indication or early detection of the any infectious or respiratory system diseases, so that we will also take as a note or consider as a danger sign, and will take immediate action for the same. Seizure and vacant stares, so in that case also we give attention to the baby and do the needful for the baby. Abdominal distension, so in that case also we need to early identify and refer if the facilities for the baby is not available in particular hospital. Bleeding icterus over palm soles, so that is also the danger sign. Then next is minimum preparation for any birth. So what like if we are already aware ki, at the time of delivery we are not aware that how much is nowadays so many diagnostic evaluation or radiological tests are available, but still we should be prepared for the delivery by considering the baby. Then next is the following should be available and in working order. Heat source, so the heat source is very should be immediately available, and before the half an hour of the delivery we should make the radiant warmer on and should maintain the proper temperature, so that immediately we receiving the baby we can keep the baby under the light source, so the body temperature can be maintained and heat loss can be prevented. Then next is mucus extractor, so the chances of aspiration will be less, and whatever the mucus is there inside the baby's mouth we should take out at the right time. Cell inflating bag for newborn size, so in case if we need to give the artificial breath to the baby, in that case the ambu bag and the mask is should be ready. Two masks for normal and small newborn, so 0 size and 1 size need to be always ready in the labor room. 1 clock, so we will count time, so we should take the pulse, we should give the these are the emergency preparations for the baby. So, at least one person skilled in newborn resuscitation present at the time of birth, so which is very much essential, and that is a very crucial time. If we'll take appropriate action within this minute or seconds, so we can save the baby. Care of the low birth weight baby newborn. Birth weight is equal to gestational duration plus intrauterine growth. So most low birth weight newborn in developing countries are term or near term, small for gestation age. The next is increased risk of hyperthermia and poor growth. Then delivery management is low birth weight babies is prone to have asphyxiated. Then management at birth according to the guidelines of resuscitation. These are the two associations, AHA and AAP, which can give the neonatal resuscitation guidelines. Consider early intubation, early CPAP, prevent hypothermia. These things we can do at the labor room, prevent hypoxia to the baby. Then what management we can do for these low birth weight babies? Arrest of premature labor. So if the effort should always be made to arrest the progress of true labor. Apart from the bed rest and sedation, a variant of tocolytic agents are recommended, but none is entirely safe and effective. So we need to, if the mother is before 36 weeks of delivery, we should delay the delivery by giving tocolytics or giving the medications or appropriate bed rest to the mother. Magnesium sulfate is more effective but have very high risk of fetal respiratory distress. Then induction of premature labor. When induction of labor is contemplated before term, either in the interest of mother or the fetus should be ascertained by the examination of amniotic fluid. For phospholipid glycerol or LS ratio we should check before induction of premature delivery. As far as possible, delivery should be postponed till fetal pulmonary maturity is assured. When delivery can be safely delayed for 36 to 48 hours, administration of dexamethasone or betamethasone to the mother in dose of 12 mg into IM in 3 doses in an interval of 12 hours is associated with significant reduction in the incidence of hyaline membrane disease. The prophylactic therapy benefit is seen more effective in female infant than male. And then labor room management, what we can do for the low birth weight babies. When a preterm baby is delivered, then the delivery room should be attended by the senior doctor, fully prepared for the resuscitation of the baby. The delayed clamping of the cord helps in improving the iron store of the baby. It may also reduce the incidence and severity of future hyaline membrane disease. But like those who are extremely low babies, that will leads to the iron overload as well as the hypervolemia in the babies. So those who are the normal or the nearby normal weight, in that conditions also only we can do the delayed cord clamping. Then vitamin K 0.5 mg should be given intramuscularly. The baby should be kept warm and transferred to nursery as soon as breathing is established. Then what management we can do for these babies in the nursery? A pre-warmed incubator should be available at all time to receive any baby with hypothermia or with birth weight of less than 1.8 kg. The following observation should be recorded by the nurse. Skin and incubator temperature hourly for 4 hours and then every 4 hourly. Respiratory rate should be observed hourly for 24 hours and then 4 hourly. Then child should be observed for apneic attacks or preferably nursed or apneic monitor. Color, journal activity, regurgitation, distension of abdominal and consistency of stool should be noted at all the time after the each feeding. Jaundice should be checked twice a day during the first week of life. Position of the baby. Prone position improves ventilation, increase dynamic lung compliance and enhance arterial oxygen. Then next is, it also makes child comfortable. It relieves abdominal discomfort by passing flatus and reduce risk of aspiration. Then next is temperature regulation. During first 24 to 48 hours of life is very critical for giving care to a child to prevent hyperthermia. Then kangaroo mother care is very much essential for the baby, and we should teach the parents for the kangaroo mother care at home also, so the baby can come to the normal parameters as soon as possible. Special attention to maintenance of the warm chain. The next is feeding. Intravenous feeding is recommended for the babies weighing less than 1.2 kg and those with severe birth asphyxia, respiratory distress syndrome, apneic attacks and acute problems like diarrhea. Fortified express breast milk is ideal for feeding the preterm babies. Mother room should be adjacent to nursery as it improves the child-mother emotional bond and promote lactation and feeding with the human milk. Strict adherence to asepsis and hand hygiene, decreasing exposure to adults with communicable disease, particularly respiratory. Then respiratory problems, continuous monitoring should be done with cardiac monitor and apneic monitor. Then oxygen is given to prevent hypoxic brain injury. Then possible safeguard should be taken to prevent oxygen toxicity. Then phototherapy, due to immaturity of blood-brain barrier, hypoproteinemia and perinatal distress factor bilirubin brain damage may occur at relatively lower serum bilirubin level. Then early phototherapy is advised to keep serum bilirubin level within safe limit and obviate the need for exchange blood transfusion. So in last video, the management phototherapy or management of jaundice and exchange transfusion we have already discussed in detail. Then next is weight record. The weight record should be recorded on alternate days, but for sick babies it should be recorded daily. Mostly preterm babies lose weight during first 3 to 4 days of life and loss is up to 10 to 15% of birth weight. The weight remains same for the next 4 to 5 days and then start gaining 1 to 1.5% of body weight per day. They regain birth weight by second week of life. Excessive weight loss, delay in regaining the birth weight or slow weight gain suggests that either the baby is not being fed adequately or he is unwell and need early attention. Excessive weight gain of 100 gram or more per day may occur in babies with cardiac failure, because water accumulation is there in the inside the baby. So that is the other sign and symptoms of cardiac failure. Nutritional supplement, hemoglobin and reticulocyte count should be checked once weekly. Multivitamin drops with folic acid supplement should be started 2 weeks at the age. Early supplement of iron is not recommended because it increases the requirement of vitamin E. Early loading of iron in infant may make them prone to infection by depletion of unsaturated lactoferrin, which is credited to possess useful antibacterial properties. Free radical lipid peroxidate in cell membrane is catalyzed by iron and polyunsaturated fatty acids, thus increases requirement for vitamin E is very low birth weight. The requirement of vitamin E are therefore related to the linoleic acid and content formula. It is recommended that vitamin E to linoleic ID ratio should be greater than 1 IU per gram of acid. Vitamin E is a powerful antioxidant and prevents hemolytic anemia and edema of prematurity. Supplementation of calcium and phosphorus are essential to prevent osteopenia of prematurity. Then transfer from incubator to cot. A baby who is able to feed properly and responsible, active with a stable body temperature, irrespective of his body weight, qualifies transfer to cot. The baby should be observed for another 12 hours after putting them incubator off to see whether he can maintain his body temperature. The infant should be stay in incubator for as short a period as possible because incubator are potential source of iatrogenic infection. The next is child parent contact. Parents must be fully informed about the progress of the baby. The mother should be encouraged to come in nursery and touch her baby. Mother should be involved in the care of to promote infant mother bonding. During her visit to nursery, routine care of the baby, art of feeding, need of warmth, importance of hand washing and prevention of infection should be explained to the mother. Principles of management of low birth weight and preterm newborn. Warmth is the most priority for the baby. Feeding is very much important. Detection and management of complications, example resuscitation, assisted respiration. As for all newborns, warmth. Lay newborn on warm mother's abdomen or other warm surface. Dry newborn with clean warm cloth or towel. Remove wet towel and wrap cover with a secondary dry towel. Bath after temperature is stable. So we can give mother education about the kangaroo mother care. Skin to skin contact to the mother as shown in the first picture. Then prevention of heat loss. So all these are the heat loss methods: radiation, convection, evaporation, conduction. So all we should prevent. So room temperature is, if the baby is having 1.1 to 1.5, so 34 to 35 is the room temperature needed. 1.5 to 32 to 34 degree temperature is needed. For 2 to 2.5 kg, 30 to 32 degree Celsius is needed, and for those who are more than 2.5, in that case 28 to 30 degree room temperature is needed. So baby should be warmly wrapped so the chances of heat loss is less. So skin to skin method, warm room fire or electrical heater, warmly wrapped baby so we can maintain the body temperature. So heated water filled mattress. So these are the other methods by which we can maintain the temperature. Radiant warmer, air heated incubators. So these are the ways which we can maintain the temperature in the hospital or in a ward setup, or we can teach the parents kangaroo mother care for the home setup and in the to the parents. Early, prolonged and continuous skin to skin contact between a mother and her newborn could be hospital or after early discharge. Then next is how to use kangaroo mother care. So newborn's position, so held upright diagonally and prone against skin of mother between her breast. Head is on its side under mother's chin, and head, neck and trunk are well extended to avoid obstruction of airways. The next is newborn's clothing. The usually naked except for nappy and cap, may be dressed in light clothing. Mother cover newborn with her own clothes and added blanket or shawl. Newborn should be breastfeed on demand, supervised closely and temperature monitoring regularly. Mother need lots of support because of for the kangaroo mother care. It is very tiring for her. Then restrict her freedom and requires commitment to continue. So that also we can teach the benefits of kangaroo mother care to the family. And we should not only if the kangaroo mother care is given by the mother is very very good, but we can teach to the other members of the family, like the baby's grandmother, grandfather, or father, or like whichever is the family member, those who having not having any of the communicable diseases which can hamper the baby, so all can give the kangaroo mother care to the baby. It is effective way of keeping newborn warm, help breathing of the newborn to be more regular, reduce frequency of apneic spells, promotes breastfeeding growth and extrauterine adaptation, then increase the mother's confidence, ability and involvement in the care of her small newborn, seems to be acceptable in different cultures and environments, contributes to the containment of cost, salaries, running cost, electricity, etc. Increase the mother's confidence, ability and involvement in the care of her small newborn, seems to be acceptable in different culture and environment, and contributes to the containment of cost, salary, running cost, that we have already discussed. Feeding of low birth weight babies. Majority of these infants are born at term. Significant proportion are born premature with inadequate feeding skills. They are prone to have significant illness in the first few weeks of life. The underlying condition often precludes external feeding. Preterm infants have higher fluid requirement in the first few days of life due to excessive invisible loss, water loss. Since intrauterine accretion occur mainly in the late part of the third trimester, preterm infants have low body store of various nutrients at birth, which necessitates supplementation in the postnatal period. Because of the gut immaturity, they are more likely to experience feed intolerance, necessitate adequate monitoring and treatment. And then early and exclusive breastfeeding, breast milk, best nourishment, already warm temperature, facilitated by the kangaroo mother. So if we can combine kangaroo mother and the breastfeeding, so it will be very much essential, effective and very good for the baby. If the breast milk is not available, consider milk formula, preterm formula until 2 kg babies, then change to after discharge formula. So low birth weight babies, fluid and feeding. Weight is, those who having the weight is 1.2 kg, gestation is less than 30 weeks. Start initial IV fluids, introduce gavage feeding once stable, shift to katori spoon feed over the next few days, late or best breastfeed. So may try gavage feed. If not sick, start antibiotic administration even without any symptoms. Those who having the weight of 1.2 to 1.8 kg, gestational is 30 to 34 weeks, start initial gavage feeding, katori spoon feeding as soon as the baby is able to suck. Then next is those weight is more than 1.8 kg, gestation is more than 34 weeks, breastfeeding, katori spoon feeding. If sucking not satisfactory on breast, shift to breastfeed as soon as possible. Then methods of feeding is, the appropriate method of feeding actually depends upon the following factors: whether the infant is sick or not, feeding ability of infant, and levels of sickness of the low birth weight babies. Sick infant, the group constitute infant with respiratory distress requiring assisted ventilation, shock, seizures, necrotizing enterocolitis, hydrops. These infants should be started on IV fluids. Enteral feeding should be initiated as soon as they are hemodynamically stable, with the choice of feeding method based on the infant's gestation and clinical condition. Then healthy low birth weight babies, enteral feeding should be initiated immediately after the birth in healthy low birth weight infants, with appropriate feeding method determined by their oral feed skills and gestation. Then guidelines for fluid requirement is: first day is 60 to 80 ml per kg per day, daily increment 15 ml per kg till 7 day, add extra 20 to 30 ml per kg for infant under radiant former, and 15 ml per kg for those receiving phototherapy. So fluid requirement is this is the chart for fluid requirement, ml per kg. Day of life, for the first day of life, if the baby is less than 1.5 kg, or there are two categories, from 1 kg to 1.5 kg, or more than 1.5 kg. So as the days, the fluid calculation is like this. So you can see the chart very nicely. They have described how you should calculate the fluid requirement. The adequacy of nutrition, weight pattern loses 1 to 2% weight every day initially, cumulative weight loss 10% more in preterm, regain birth weight by 10 to 14 days, then gain weight up to 1 to 1.5% of birth weight daily, excessive loss or inadequate weight, cold stress, anemia, poor intake, sepsis. Then what supplements we can give to the low birth weight babies? So vitamins is IM, vitamin K 1 mg at birth we will should give, vitamin A 1000 international per day, vitamin D 400 international unit per day, or iron is oral 2 mg per kg per day from 8 weeks of gestation. Common problems and its management. So respiratory distress problems, usually due to hyaline membrane disease. So how we can assess antenatal steroids and CPAP, bubble CPAP or surfactant we can give to the baby. Then next is infection. So antibiotics we can give to fight with infection. Supporting treatment we can give, like if the baby is having the symptomatic treatment we can give. Nutrition and oxygenation and warmth we can give to deal or to fight with infection. Then immunotherapy if it's needed, or if the baby is very much complicated. Hyperbilirubinemia, so according to the level of total serum bilirubin, phototherapy, feeding breast milk, fluid therapy, antibiotics according to the condition of the infection. Apneic spells apnea of prematurity, so very often in the those who are less than 1.5 grams. So complications is hypoxemia, oxygenation and breathing stimulation. Aminophylline or theophylline we can give, mechanical ventilation to the babies. Then hypoglycemia, how we can treat the treat the hypoglycemia, awareness of the symptoms, and sometimes it's asymptomatic. Blood glucose level we should monitor continuously. Hypoglycemia if the sugar level is less than 45 mg per dl. Then the dextrose infusion we can give, glucose infusion rate we can adjust according to the body weight. Then intraventricular hemorrhage due to weakness of blood brain barrier and hypoxemia, decrease of consciousness, deficient neurologics and seizures, USG or CT scan, consult to the pediatric neurology division and neurosurgery. Then metabolic acidosis due to hypothermia, hypoxemia and infection confirmed by the clinically and laboratory, should be corrected by considering anion gap, administration of bicarbonate, awareness of false root. Then home care, so after discharge we can counsel the parents to how to take care of these babies at home. So the infant should be well covered, like woolen cap, socks and mitten should be worn, so we can reduce the maximum, we can reduce the heat loss to the baby. Infant should be lie next to the mother, it is useful and biological controlled heat resource. The next is in winter, room should be warmed with room heater. The cot of the mother and infant should be located away from the wall or reduce radiation heat loss. The next is mother should be trained to assess baby temperature and advised to ensure that extremities are warm and pink. The visitor's handling should be restricted to bare minimum. The hand should be washed before touching to baby and before feeding, because the chances of infection is very much common. The linen should be clean and sun dried. Feeding, so breastfeeding should be encouraged to the mother. Criteria for discharge, so if the baby is low birth weight baby, so what criteria we should prefer for the discharge of the baby? Screening tests are performed before discharge or on follow-up. Those who are ROP detection in infants less than 32 weeks and auditory brain stem evokes response ABARE. Then nutrition supplements include multivitamin, iron, calcium and vitamin D are started. Immunization with BCG, hepatitis and OPV is given. Weight gain should be consistently demonstrated before discharge and plotted on growth chart, which can be used for follow-up to determine if the growth is adequate. Baby should be feeding well. If it is alternate feeding technique like pellada feeding, the mother should be confident regarding its detail. Absence of danger signs and complication of treatment like IV antibiotics. If baby is being discharged on oral medication, then parents should be well educated regarding how to administer the medications. Method of temperature regulation, either kangaroo mother care practice or other method, should be well known to the parents. All danger signs should be explained to the parents in details like history of difficulty in feeding, movement only when stimulated, temperature below 35 to 35.5 degrees Celsius or 37.5 degrees Celsius, respiratory rate over 60 breaths per minute, severe chest indrawl, history of convulsion, general nursing management in low birth weight baby care. So maintenance of body temperature. So thermal stability, maintenance of normal core temperature with narrow limits results in balance existing between production and conservation of heat and dissipate. So provision of neutral temperature. Then thermal sensor should be always placed as a part of body that is exposed to the circulating incubator air and not where the skin temperature may be influenced by the cooler substance. Child should be put in incubator. If incubator not available, radiant warmer should be available. Mother should be educated about kangaroo mother care. Then proper checking of vital signs. So child should be well observed for apneic episodes or any other type of periodic breathing. Then the prevention of infection and injury. So hand washing and complete sterilization or disinfection. Equipment and supplies of two important points to be remembered to prevent the risk of nosocomial infection. Hand washing should also be done in between handling different infants. Then proper infusion pump should be used so that exact amount of fluid is minute is given to infant. Nurse must look infiltrated fluids around insertion site like palmar area. Then the insertion cannula is at the back of hand. Before giving any medication, nurse should be clear about the action of the drug and should be prepared for any emergency condition like if vitamin K should give given. Nurse should be prepared with analogous novo biocin and oxygen. The computation, preparation and administration of parents fluid or medication should be done with serious responsibility of the nurse. Then use of equipment.